Hi guys, this is a review of Lab 12, the middle mediastinum and the heart. So really what we're looking at is the mediastinum is the middle section of the thoracic cavity, which we can see here. It contains the heart, esophagus, thymus, trachea, aorta, vena cava, and then a whole bunch of nerves. There are 4 regions to it. We're dissecting for this lab, it was all about the inferior mediastinum, which has 3 parts: anterior, middle, and posterior. And then there's also the superior mediastinum, but we're mostly focused on really the heart section, so middle mediastinum, and overall, that makes up a third of the inferior part of the mediastinum. So what were the learning objectives? Looking at the boundaries and structural relationships, looking at the pericardium, which goes with the heart, its relationships to the great vessels in the heart, the external structures, including the coronary vessels, and then the internal structures of the heart. So not too bad, decent amount of overlap with our histology work that we've done this past week. So what are the boundaries of and divisions of the mediastinum? So really we have 2 main divisions, as we alluded to already. We had the superior mediastinum, and then we have the inferior mediastinum, and that's broken up basically by the sternal angle. So you can just draw a nice transverse line. Everything above it is superior, everything below is inferior. Inferior mediastinum has 3 compartments: anterior, right here, middle, and posterior. We are mostly concerned, for the purposes of this lab, we're concerned with the middle mediastinum, given that this section here is going to house the heart, the sac that goes over the heart. It'll have the roots of the great vessels, the arch of the zygous vein, which we know is where a lot of the intercostal veins drain into, the main bronchi for breathing, and then phrenic nerves and the pericardiac phrenic vessels. All right, so looking at the middle mediastinum, really we're going to be focused on, we have an inferior border of the diaphragm. Superior is the transverse line you can draw from the sternal angle, and then we're going to be looking at really the pericardial sac. All right, so can you define the pericardium and discuss vessels and nerves? So the pericardium is the sac that goes over the heart. It has 2 main layers. We have the external fibrous pericardium, which is stiffer, and the idea is that therefore will keep the heart from, say, becoming massive quickly, or as we'll see with pleural effusion, you don't want to have a big change in liquid around the heart. So having some rigidity, so fibrous layers, is good for keeping the heart safe. And then we have the internal sac, which is the serous pericardium, which is serous meaning it's a layer that's in contact with fluid. So in between those 2 layers of the internal sac, you're going to have a pericardial fluid that's going to allow the heart to move around. But the internal sac, and we'll see more of this in just a second, actually has 2 layers: the parietal layer, which is adjacent to the fibrous pericardium, and then a visceral layer, which lies on the heart. Okay, so again, we're looking at pericardial sac. We have the right phrenic nerve and the pericardiacophrenic artery and vein that's coming down the side here and going to the diaphragm. And then on the left-hand side, we have basically the exact same thing: left phrenic nerve, left pericardiacophrenic vessels leading to the diaphragm. And so what nerve transmits pain signals from the pericardium? That would be the phrenic nerve, which we can see is giving branches into the pericardium right there. All right, what is the pericardial sac attached to inferiorly? Well, we can see it's attached to the central tendon of the diaphragm, so the diaphragm. Okay, then can you differentiate between the serous and fibrous pericardiums and discuss the pericardial cavity? So we said that pericardium, again, has 2 overall layers: the external fibrous layer and then the internal sac, which itself has 2 layers. So we have a couple of different ways of breaking that down, but right, outside layer, fibrous layer, outermost layer, and then we have the serous pericardium, which is itself made up of 2 layers: the parietal, which is adjacent to the fibrous, in contact with it, and then that loops around, and we have the visceral layer, which is on the heart, and then in between those 2 we have the pericardial fluid. And so you can see that, right, why can we say this is 2 layers overall? Well, on the outside right here we have the fibrous layer of the pericardium, and then right here we have the parietal layer of the serous layer of the pericardium, and then you can see it loops around and becomes the visceral layer of the pericardium. So overall 1, and then this is 2 layers, and in between the second layer, the parietal and visceral, we have this fluid, the pericardial fluid, to allow the heart to move a little bit. Okay, so that's it. Stiffness protects from pericardial effusion, too much liquid getting in here quickly, and that is just to protect the heart. What is effusion? Well, effusion is a buildup of fluid in the pericardial sac, and so we have leaking of fluid from the pericardial capillaries into the pericardial cavity, and this is not good, because if you have a lot of fluid in there, it's compressing on the heart, and it's going to make it harder for the heart to go through its cycling of pumping. It's pushing on the outer wall of the heart, it's compressing it, and so this will in particular, when we're talking about the expansion of the atria to bring in blood, it's going to be harder for if there's material pushing on the atria, then it's going to be harder for blood to get in. And so, this is just not good overall. And you could see a similar thing with the hemopericardium. If you have blood entering the sac, exact same thing. It's going to be harder for blood to get into the atria, so then you're going to have extra pressure in the superior vena cava, and you'll see that as veins in the neck and head engorge, as it's harder to, you have increased pressure in the superior vena cava, which we know is going to get to your jugular vein, and so you'll have engorgement of those veins. All right, so then removing the heart, during this lab we made a cut right here across the different great vessels. We have the superior vena cava, ascending aorta, the pulmonary trunk right here. Then we have a couple questions. What sinus is related to the great vessels at the level of the dashed lines? and this is the transverse pericardial sinus. And then when you lift the apex and inferior margin of the heart to remove it, what sinus did you enter? The oblique pericardial sinus. So the pericardial sac, where it meets right surrounding the heart, but it also attaches superiorly to the great vessels. And so as a result of this, there's going to be some gaps. And so you have a gap that the transverse pericardial sinus, and it's going to separate the arteries from the veins. So you see we have the pulmonary veins here, and then above that the pulmonary artery. So the transverse pericardial sinus, and then below that we have the oblique pericardial sinus, which is formed by reflection of the pericardium onto the pulmonary veins, right? So pulmonary veins, which are bringing oxygen-rich blood back to the left atria. All right, so can you define the transverse and oblique pericardial sinuses? We just went over that. Great. And then noticing the relationship to the pulmonary artery and veins, transverse is separating them, and then the oblique is really underneath them. All right, so external features of the heart. We'll take a look at a physical heart model in just a second, but if we're looking at, this is the anterior surface of the heart right here, and here we have the apex, which in our clinical skills class we were using it to measure the point of, this would be like the point of maximal impulse that we're auscultating with our stethoscopes, or we're palpating and then later we auscultate. And anyways, so I've labeled different structures that are pretty important, starting with the coronary arteries, right? Coronary like crown, so a crown around the heart. So we have the right coronary artery, right? This is the right side of the heart, and we can see that here. Then on the other side, the left side of the heart, we have the left coronary artery, and it has a number of different branches. Here we have the right ventricle and the left ventricle, and so this branch that's going downwards, this is the anterior interventricular branch of the left coronary artery, and then we have the circumflex branch up here, all right? But I think the way to keep these straight is, what view of the heart are you looking at? This is the anterior part of the heart, right? If you were just open up somebody's chest, you cut away the pericardium, this is the view that you would be presented with. And so on the right-hand side, you have the right ventricle, and then on that same side, you'll have the right coronary artery. On the other side, you have left ventricle, left coronary artery, all right? And then that brings us to sulcuses. So the grooves for these vessels that are basically, they separate the different chambers of the heart. So we have the coronary sulcus here, which is a groove between the right atrium and right ventricle, and that groove is going to house our right coronary artery. Then over here we have the anterior interventricular sulcus, right? Because we have right ventricle, left ventricle, so inner ventricle. And then finally, just quickly touching on the veins, because we'll talk more about this in just a second, we have the great cardiac vein going with the anterior IV branch of the left coronary artery, and then over here we have the small cardiac vein. Okay, so let's move on to the back, and then we'll take a quick look at the model of the heart. So on the posterior side, we have really the kind of the cool thing here. We have the coronary sinus, and this is slightly frustrating because the coronary sinus is actually a vein that drains into the right atrium. So why not just call it like coronary sinus vein or something? But we have that is going to be fed by the great cardiac vein, which we saw a branch of right here. And then we also have the small cardiac vein, which we saw a branch of on the right anterior side of the heart. Okay, so small cardiac vein, great cardiac vein, they lead into the coronary sinus, which itself drains into the right atrium, where you can see the inferior vena cava is also draining into this right atrium right here. So it's these ones, the circumflex left coronary artery right here. That's the branch of the left coronary artery. And then on the other side, we have the posterior IV branch of the right coronary artery. And specifically, again, we'll talk more about this in just a second, but this is the posterior descending artery, and that's going to determine whether basically what left or right coronary artery, either the left or right coronary artery, which one is giving the branch that does provides blood to this region. The posterior IV sulcus is going to determine if you're right dominant or left dominant for your heart. And so this one is right dominant because this descending posterior branch through this sulcus is from the right coronary artery. Right, if there's left, then it would be left dominant. All right, and then another thing, so this vein right here coming down is the middle cardiac vein, and then pointing out, we have our left ventricle and we have our right ventricle over here. And this is the surface that's going to be in contact with the diaphragm below the heart. All right, so this is basically what we talked about. Can you find the branch of the SA node? So we know the SA node is our pacemaker, and we're going to get the branch from the right coronary artery. Right, you can see the right coronary artery here, and we have a branch going to the right atrium, which is where the SA node is housed. Then we have, so how does the AV node get its blood supply? So it gets its blood supply from a branch of the posterior descending artery. And again, so the posterior descending artery is this artery right here that goes into the posterior interventricular sulcus. Again, that's this guy right here. And we said that this branch sometimes comes from the right coronary artery, but you could have that branch come from the left coronary artery instead. And so is this a left or right dominant heart? Well, this branch right here, the posterior descending artery, also called the posterior interventricular artery, here is coming from right coronary, so this is a right dominant heart. All right, that's 85% of people, 15% of people have the left dominant heart. All right, and so the AV node, which is the second main point in our conduction pathway within the heart, right, goes SA to atrium to AV nodes, that is going to get its blood supply from a branch of this posterior descending artery. Okay. All right, and then also important to note, we have a marginal branch of the right coronary artery on the anterior side, and then in the back, we've mentioned this guy quite a bit. Left coronary artery we have coming out here, we have the circumflex branch, and then we have the interventricular branch, that's anterior, so the anterior IV branch of the left coronary artery, and then that's what's further, we have the diagonal branch of the anterior interventricular artery. Okay, on the back, can you identify coronary veins that are related to the specific coronary arteries on the interior side of the heart? Well, we have the right coronary artery, and then the veins that go with it. We have the anterior cardiac veins, and then we have that small cardiac vein as well. And the small cardiac vein is draining into the, the coronary sinus on the back. Okay, and the anterior cardiac veins are going to go directly into the right atrium. On the left side of the anterior part of the heart, we have the circumflex branch of the left coronary artery. The great cardiac vein is going to work that one. It's also going to be giving rise to the anterior interventricular vein, which will go with the anterior interventricular branch of the left coronary artery. Okay, so let's just take a quick look at the physical model of the heart, and then we'll get back to looking at the back side of this. All right, so here we have our model of the heart. This is the view you get, the interior view. If you just opened up somebody's chest, we have the right ventricle, left ventricle, right auricle, and then below that is the right atrium, left auricle, below that is the left atrium. And then we have the pulmonary artery overall, and then we can see back here the pulmonary veins coming in and delivering to the left atrium. So just looking at the surface anatomy, we have the right part of the heart, so this is the right coronary artery. Then the left part of the heart, we have the left coronary artery, and then this is the IV sulcus, so this is the left interventricular branch of the left coronary artery, and then you should have the circumflex branch coming around here, which we can start to see. Yep, so left circumflex branch, or the circumflex branch to the left coronary artery. All right, and we have the sinus. I believe this is sulcus over here, which is correct. This is the sinus that drains into the right atrium. Then we have our posterior sulcus, and so this was the middle cardiac vein coming down. Here we have the right coronary artery, and it is giving us that posterior descending artery. So this heart is right dominant overall. Okay, so not too bad. Let's go back to what we're doing. Okay, back to the posterior side for coronary vessels. Can you find the coronary sinus? All right, we've already gone over that right there, and then the coronary veins related to particular arteries. So we have the great cardiac, which is associated with the circumflex branch of the left coronary, and then we have the posterior cardiac vein, which is branching off of the great cardiac vein, and then we're back to our posterior sulcus, and so we have the posterior interventricular branch of the right coronary artery to the right posterior descending, and then with that is the middle cardiac vein, and then we have the small cardiac vein coming around. All right, so not too bad. Let's take a look at the atrium. So the atrium, what structure is sending it blood? We have the superior vena cava, the inferior vena cava. What structure receives its blood? Well, the atrium is our waiting chamber, right? It's going to send its blood to the right ventricle, and then a couple of things to notice. We have this line right here, and this is the crista terminalis on the inside of the heart. On the outside, you actually see something that's called like a groove there. On the outside, that's the sulcus terminalis cordis, and that separates the basically two different parts of the atrium, like the primordial atrium, which develops first, and then the rest of the atrium. And then a couple other things to note: the atrium is lined by pectinate muscle, so musuli pectinati. I can't pronounce anything. And we'll compare that to the ventricles in just a minute. And then we have the fossa ovalis, which is going to which was open for infants, and then as soon as they breathe, this closes and eventually seals. All right, then we have the right ventricle over here, and then important to know, on top of the right atrium, we have the right auricle, which just provides some extra room for blood to collect in, and it has those pectinate muscles as well, so it can contract. All right, not too bad. We do have the SA node is in here. The AV node is going to be approximately right here near the opening of the coronary sinus, which we said was where the great cardiac vein and the small cardiac vein are going to drain into. The right ventricle, we can see we have the tricuspid valve that's separating the right ventricle from the right atrium. The structure that is sending its blood to the right ventricle, we know is the right atrium. And then what structure is getting blood from the right ventricle? It's going to be the pulmonary artery, which is going to the lungs. A couple things to note here. We have the trabeculae carnae. So when we looked at our cadavers in lab, we saw this really strangely textured muscle, kind of looked like a spider web almost on the inside of the atrium. This was the trabeculae carnae. It's just regular muscle elevations. The rest of the muscle in this region is our papillae muscle, which is connected to the chordae tendineae, which is a tendon that is attached to the leaflets of our valve. And so the idea is that those will keep our valve from inverting and allowing blood to go back into the atrium. We don't want that to happen. All right, so then, yep, that's pretty much it. This one's maybe worth pointing out. The conus arteriosus is just a smooth region. The rest of the ventricle is covered in the trabeculae carnae, and so this is really smooth right before the pulmonary valve, and I think that has to do with fluid flow, but I'm not entirely certain on that. All right, left ventricle. So left ventricle is the pump that's sending blood to the rest of the body, and so this looks basically identical to the right ventricle, but it's much bigger. It has the bicuspid valve, and then it also has the aortic valve. The bicuspid valve is going to be between the ventricle and the atrium above it. We have the chordae tendineae, the trabeculae carnae, those weird regular muscle elevations. We have the papillary muscle that's going to attach to the chordae tendineae, which is attached to the mitral valve in this case. And then here we have the left atrium, where we have the pulmonary veins are leading into the left atrium, delivering oxygen-rich blood to the atrium. All right, and then when the ventricle contracts, it's going to pump blood out of the aortic valve into the aortic arch, which will split into a number of different branches and then continue on as the descending aortic, aka the thoracic artery. All right, left atrium, we're getting our blood from our pulmonary veins. We have the other side of the foramen ovale, which we said was open in infants or open, still at the moment of birth. When they get born, they breathe, it closes, and then permanently seals. We have the mitral valve between the left atrium and left ventricle. All right, so not too bad. relatively straightforward. All right, cardiac skeleton, we went over this in histology quite a bit. Annulus fibrosus are these rings. There's 4 of them, and they have a number of different functions, but they are constraining the size of the valves. So they stabilize the valves. As part of the skeleton, they're made up of cartilage, and they're not good conductors of electricity, so they are insulators, and they're preventing the spread of electrical impulses and confining it to the conduction system, right? The SA to AV to bundle of His, the branches to Purkinje fibers, the ventricles. Right. We also have the trigones, which are these like triangular bits that are between the rings, and then I don't think it's written here, but we do have a I think it's the septum membran. I can't pronounce it, but you have a part of the cardiac skeleton goes into the intraventricular wall, so the wall between the 2 ventricles, to sort of anchor the skeleton in place. All right, cardiac innervation, we have, right, the whole point of the heart is that it is self-sufficient, like it pumps automatically, right? That's what the SA nodes, AV nodes are doing, but we can change heart rate, right? If you are starting to run, slowing down, etc. So we have the parasympathetic nervous system and the sympathetic nervous system, and how they go about innervating is a little bit different. The sympathetic nervous system is going to have branches coming from the spinal cord, thoracic 1 through 4. Those are going to go along and get to the sympathetic trunk here, and so they'll come from a vertebrae. They'll get to this trunk. If they, one or two things can happen. They'll synapse at the ganglia at their level, and then they'll send their postganglionic. The second neuron will just go straight down, and it will join the deep cardiac plexus or the superficial cardiac plexus, and that ultimately means it's just going to end up either on the surface of the heart or deeper to the heart. But the sympathetic nervous system is going to use acetylcholine at the ganglion and then neuroepinephrine for the beta-1, beta-2 receptors on the heart. The parasympathetic nervous system is going to send, basically it's the vagus nerve, which is a nerve from it's a cranial nerve, and it's going to be super long, and it's going to come down, and it's going to synapse right in the organ. So the postganglionic neuron, the second neuron, is actually located in the organ itself, and the second one's going to use acetylcholine to our muscarinic receptors, sort of lungs, muscarinic receptors on the heart, okay? And then in particular, we need to know a couple of things. For the parasympathetic, it's going to be acting on the SA and AV nodes. It's going to be in the atrium and not very much in the ventricles. It's the vagus nerve overall. It regulates heart rate and the force of atrial contractions, but nothing with the ventricles because it's not really present in the ventricles, right? Branches of the vagus nerve is what we're saying, right? So we have, you can see here, the vagus nerve descending all the way to the heart, and then it's going to be focused on the atria, right? The right atria houses the SA and AV nodes. Okay, then the sympathetic nervous system will attach to the SA node in the right atrium. It will also go to both the atria and the ventricles, and we already said sort of the pathway, TV1 through TV4 is where it's coming from. It goes to the sympathetic trunk. It will either ascend to ganglia higher up, or it will synapse at a ganglia at the same level it started at, and then the post-ganglionic neuron is just going to, it's already at the, or it's not already at the heart, it's going to go from that ganglia directly to the heart, and it may go through the deep cardiac plexus or the superficial cardiac plexus. All right, so that's it, not too bad. Heart sounds, we're looking for the lub and the dub. We had different places to auscultate depending on what you're trying to hear. S1, S2, lub and dub. The lub is the tricuspid and mitral valve. You want to do tricuspid, you want to be to the left of the sternal body at basically rib 5 level. And then for the mitral valve, you can find the point of maximal impulse, which is typically a little bit below the nipple on males, but the 5th intercostal space overall. All right, then the dub S2, when you auscultate, when you listen, is the pulmonary valve and aortic valve closing. Aortic valve, you're going to just be to the right of the sternum, and then the pulmonary valve slightly to the left of the sternal angle. Okay, and that's it. Good job, guys, and see you next time.